So we'll start at sharp at 3:30. Just wait couple of 1 or 2 minutes, then we'll start. That's more attendees will join in the seminar.
So how many did we have yesterday?
Yesterday it's for 100 plus.
Yes.
We had 137 yesterday.
And apply is always controversial.
Yes.
Just 1 more minute, then we will start. So today is second day of the seminar.
Good afternoon, everyone.
Good afternoon. Good afternoon all. On behalf of Warfarin India and Dr. Lalpeth, I would like to invite in second India Autoimmunity seminar. It's day 2. Yesterday we have started our seminar. So today we have two speakers, Dr. Vijay Kumar Rao and Dr. Savino Sasha. One international and one national speaker. And today again moderator is Dr. Anil Arora from Dr. Lalpeth. He is HOD at Immunology Lab. So over to Dr. Anil Arora for today's session. Sir, you are on mute.
Yeah, good afternoon, everyone. I welcome all the participants for this second autoimmunity seminar. The first one, which we had physically in Delhi. This is the second one. We're going virtual with this. So we already have our speakers with us. I welcome both the speakers, Dr. Vijay K.R. Rao and Dr. Savino. And also we in our panel, I welcome Dr. Vanna Lal, who is Executive Director of Dr. Lalpeth Labs, and also Dr. Dinele from Welfen. So I welcome all. So we'll start. Yesterday we had a feast of those two topics. We had a webinar on that. So today we're going to the second session. In the second session, as we were talking with just before this webinar, no session on no seminar on autoimmunity is ever possible without a session on ANA. So today, as I told you, we have with us Dr. Vijay K.R. Rao, who is a senior consultant, consultant rheumatologist at Divisha Arthritis and Manipal Hospital at Bangalore. He is well versed with this topic of ANA, and he will be telling us about the specificities of ANAs and what all should be there. We should look at in the ANA reports and all. Like he will be giving us in and out of our ANA testings, how it should be reported and how it should be interpreted. So Dr. Vijay Rao, he studied his MBBS at Bangalore Medical College. Then he underwent a specialist training in internal medicine in West Midlands, UK, and obtained his MRCP from UK, general medicine. Then again, super specialist training in rheumatology in some of the reputable hospitals in UK, and obtained again MRCP rheumatology from UK. Then he did his fellowship also in SLE and rheumatic disease in pregnancy at the prestigious Lupus UK Center of Excellence, Birmingham, with everybody knows that with Professor Caroline Gordon. He was awarded the prestigious FRCP degree from Royal College of Physicians in Edinburgh, Scotland. So from his profile only, we know that I don't think we'll be finding a better person than Dr. Vijay K.R. Rao to tell us something about ANA. And his experience, he worked at many places as a consultant rheumatologist at Queen Elizabeth Hospital. Then his major areas of research interests include lupus, CTDs, then the management of this rheumatic disease in pregnancy. And he has attended as speaker many international and national rheumatology meetings. And he's also assistant editor in the Indian Journal of Rheumatology. and is a member of Indian Rheumatology Association and the British Society Rheumatology. And he's also examiner for MRCP exams to be held in India. So with this introduction, I'd like to hand over the mic or stage to Dr. Vijay K.R. Rao to tell us more about autoimmune ANA testing in autoimmune rheumatic diseases. Over to you, Dr. Rao.
Thank you very much for the opportunity and introduction. Very glad to share this my talk with esteemed colleagues. As you rightly said, ANA is something very mystical because the more you know about it, you kind of come to know the fallacies in the test, and you know that most of the diagnosis which happens probably is not adequate in terms of the information we get from the reports. In fact, when I opened my center 3 years ago in Bangalore, so I do a half and half practice. I practice in Manipal, which is a tertiary or quaternary care based setup in Bangalore. It's the third largest chain of hospital chain, corporate chain in India. So now that we've acquired even Columbia Asia, Manipal has acquired Columbia Asia chain as well. So I came back from the UK in 2016 and been with Manipal since then. So as you know, in the West, everything is standardized, and we never had to worry about how to set up a lab and what are the things you need to ask a microbiologist or immunologist in the report, because it was all there for you. So Manipal, when I came down, it was already set up. But when I set up my clinic, then that's when I realized I had to change 3-4 lab as my associate partners because I wasn't happy with the reports. And right now, Anand Lab is sort of catering to our test because I see that reports are 100% accurate. And I have great belief in LAL reports as well, because whenever patient comes with LAL reports, I see that consistency is something which is very good in terms of that. So I thought that, there are two fantastic nature reviews in terms of ANA testing, which talk in depth about the specifics of ANA test in autoimmune rheumatic diseases. I'm just going to focus on autoimmune rheumatic disease only because that's the area of my expertise. So with that introduction, ANA becomes important in autoimmune rheumatic diseases in the following core diseases. So undifferentiated connective tissue disease clinically means somebody has an ANA and they just have joint pains. So somebody comes with history of inflammatory arthritis, that is painful swollen hands and feet, worse in the mornings. And as a part of your screening test, you do a rheumatoid factor. I do a rheumatoid factor by nephelometry, and I do anti-CCP, and I do ANA by IFA, immunofluorescence test. And I see that in undifferentiated connective tissue disease, they have an ANA. When you do a starting dilution of 1 in 100 at least, or 1 in 80, you see that the ANA would be at least 1 in 160 or 1 in 320. But they don't have any other clinical features of a mixed connective tissue disease. Mixed connective tissue disease, for those of you who don't know, is combination. We have features of RA, that is inflammatory arthritis, especially bond or rheumatoid-like features in hands and feet. Then we have features of Raynaud's present in them. We have myositis, we have scleroderma, lupus, and 99% of them are RNP, anti-RNP positive. Okay, so that's a distinct entity in itself. Lupus, we are a bit more aware of that. So with the latest clinical criteria of ACR ULR, which has not even come into clinical practice yet, but the last one we had was SLIC criteria, and the older ones was ACR criteria. So we need at least clinical features of inflammatory arthritis. We need malar rashes, photosensitivity rashes, mucocutaneous ulcers, serositis, cytopenias, nephritis, involvement in terms of proteinuria or blood, and several features. So at least you need to have 3 or 2 to 3 of these of clinical features, and in ANA, of course. In the newest SLE criteria by American College of Rheumatology and EULAR, the entry criteria is 1 in 80. Of course, it has its own problems. So they realized that 1 in 80 was a decent titer to actually be a good screening test. So scleroderma, systemic sclerosis, we know that they have skin involvement, they have vasculopathy, they have inflammation, fibrosis, and vasculopathy as the 3 cardinal features in the pathogenesis. And of course, dermatomyositis and polymyositis. So where you see myopathic features with raised creatine phosphokinase CPK, and cutaneous features, rashes in terms of dermatomyositis. So ANA becomes crucial in all of these. There is a bit of myth in this, that most people think that all these diseases should have ANA positivity. That of course holds good if you actually combine your immunofluorescence and solid assays. I'll talk about that because there are some assays which becomes negative in immunofluorescence, such as dermatomyositis, polymyositis, and even Sjogren's, and to some extent systemic sclerosis. So we need to know or we educate our clinicians as to what exactly they have to ask in the reports. Unless and until we ask, it won't be done. So just to talk about introduction, ANAs are basically autoantibodies that target a wide variety of nuclear and cytoplasmic antigens. This, my friends, most of them miss. They only think that it's nuclear. It is definitely cytoplasmic as well. So it looks very basic, but it's often missed about this thought. And it's the most sensitive serological marker for evaluating patients with suspected connective tissue diseases. That what I went through the circle of diseases. And they're also these days called ANA-associated rheumatic diseases. What do I mean by sensitivity? I mean by sensitivity, it's a good test to actually say whether this patient might have it, or it's a good test if the patient does not have it, if it's negative. So that's basically a good sensitivity. But it's a useless test just based on the positive value to say definitely that this patient has it. I'm trying to explain it in a very simple way for audience who are not rheumatologists or immunologists. So we need further information based on a positive ANA to actually diagnose a connective tissue disease or ANA-associated rheumatic disease. So the diagnostic potential of ANAs date back way to the discovery of LE cells, which are basically polymorphs which contain phagocytized nuclear material. And that's where the pathogenesis comes. Basically, the phagocytosis of the nuclear debris leads to antibody production, antigen antibody interaction, complex formation, complement consumption, and immune activation, chemotaxis, inflammation, cytokine release. So that's the whole story. That's where things start, basically by phagocytosis of the nuclear material. And it's not only to classify patients with connective tissue disease, the role of ANA serology, but also to stage and subset of their disease, like I told you, which category do they belong to. And that ultimately helps us in determination of immunosuppressive therapy. For example, if a mixed connective tissue disease patient comes to me with just isolated joint pains with no lung involvement, when I do the HRCT scan, I don't use mycophenolate, I use methotrexate. But if patient has dominant lung disease, such as interstitial lung disease, but less of joint pains, I use mycophenolate because mycophenolate works better for lungs. Methotrexate works better for joints. So that is where, subset and naming the disease. Often my professor in the UK, Professor Caroline, used to say, always put the diagnosis at the top in your letters because that makes things fall in line. So that's quite important. And look at this. Trials with SLE have this problem. That's why classification criteria have come to place. So 30% of them with SLE were screened for a clinical trial for a new therapy are ANA negative. So how are you going to diagnose the disease? So knowing the assay and the test is quite important in this context. And it's also a proven fact that those who have high ANA titers respond well to therapy. I often have found this. I mean, I've found cases where ANA profile, ANA immunofluorescence, and solid assay is negative, but they have kidney disease on a histopathology, and they're very refractory. Even rituximab doesn't work, cyclophosphamide doesn't work, so they eventually end up with kidney transplant. So this is definitely, shown in various papers that ANA negative patients are quite refractory. Yeah. Uh, Now the problem comes when there's a ANA test negative result. So most commonly you have to retest it with another kit of the same type, that is immunofluorescence maybe, or use a different platform, solid assays, to resolve uncertainty. And always, I've found this, good labs do that. Cytoplasmic staining should be reported as ANA positive or not negative. So, in which nuclear is negative and cytoplasmic is positive, you give the test report as ANA positive. That will resolve your confusion and ambiguity. Often, I've seen physicians asking me, hey Vijay, I mean, they're given cytoplasmic staining as positive. Do you think lab has done a mistake? That probably, it's that misunderstanding that cytoplasmic staining doesn't exist. So that's where the importance of knowing multiple assays and their clinical importance is. Endpoint titer for immunofluorescence uh, or use of a quantitative assay for solid assay for a specific antigen is very, very important. And why is it so? So because you basically categorize a serological profile of the patient, and it's more higher the titer, the more avidity or the pathological nature of the antibody is. So endpoint titer is quite important, very important. But having said that, I don't rely on ANA to prognosticate disease. Never I do that, and should not be done. Often patients have this understanding that, doctor, you're not done in ANA after 1 year of therapy. I say no, it's of no value. So there are other methods, symptom wise, basically, mainly, or a complement or an ESR and CRP, and normalization of several other symptoms or even parameters of the disease. In ANA negative, essentially doesn't mean that I stop the therapy. It only means that the immunological process is quietened down, the disease is in remission, but it's not a proof that you can stop therapy. You probably cannot do that. And we often don't repeat that for that context. Having said that, I've seen in Prof. Caroline's Lupus UK Center of Excellence, where patients are on just hydroxychloroquine therapy for lupus and for years together, and she wanted to withdraw the patient from her clinic because the clinic was overloaded and park the patient with the primary care physician. She often used to do ANA to see how the disease is and write to the GP that ANA is negative by both solid assay and immunofluorescence, and the patient is been on just hydroxychloroquine or antimalarial and is considered as in remission. So that way it's quite useful in terms of endpoint titer. So the testing involves two parts. So first part is whichever patient you're suspected to have an autoimmune rheumatic disease, the clinical features I mentioned in the initial part verbalized. So a screening ANA is ordered to detect the ANA regardless of the antigen specificity. So better is always immunofluorescence to start with, and the lab should actually be aware of doing a cytoplasmic staining if your clinical features are very strongly suspected. So because if some diseases immunofluorescence comes negative and cytoplasmic lights up, staining lights up. Now after your screening ANA is positive, then additional test or ANA profile or extended nuclear antigen ENA is done to actually subcategorize the disease, which has important diagnostic and prognostic implications. So depending on the patient's clinical scenario, a positive ANA, you might need double-stranded DNA antibodies, or by ELISA or antibodies against one of the ENA profile. Most of the cases we do ENA profile here, which would cover ROLA, Smith antigen, topoisomerase or SCL70, and then Jo1 and other tRNA amino acid synthetases, and even RNP antibodies. So anti-ribosomal P and anti-centromere comes in a part of all this ENA or ANA profile. I often see some of the prescriptions where physicians probably would directly go for ANA profile. Don't do that. Ask for a screening test first by either an immunofluorescence assay or a solid assay, and then proceed further beyond. So an ideal screening test, ANA has a 95% sensitivity. Specificity and positive predictive value, as I told, is quite low. And 35% of above 65 years are ANA positive. So it's definitely an age-related test. However, this is very true that those with ANA have less than 3% chance of developing lupus. But with typical features of connective tissue disease, a negative ANA will not exclude an SLE. Bear that in mind. And sensitivity of ANA is better with immunofluorescence test than enzyme tests. So, but I would combine both for the reasons I would describe next. So, what are the testing methods? So, immunofluorescence assays, basically patient samples are typically incubated on a slide covered with monolayer of HEP2 cells or human epithelial type 2 cells. And any antibodies from anti-nuclear antibodies from the patient that bind to the antigens, autoantigens in the HEP2 cells are detected by the detection antibodies. That is the fluorescent label anti-immunoglobulin antibodies. Then they're visualized using a fluorescent microscope. So the test report typically should contain an ANA titer and a staining pattern. So there is a start dilution, end dilution, staining pattern, and the strength. Yeah. So this is typical glass slide where you see that this is the autoantigen in the HEP2 cell, the autoantibody in the patient sample, then the detection antibody in the fluorescent tag, and you use the microscope. So an example would be 1 in 80, and staining pattern example would be fine speckled antibody staining pattern in the nucleus and cytoplasm. That's how a report should look like, a correct report. Okay. Now, what is the second type? That is the standard solid phase assays, or SPAs it's called. So with the solid surface, that is polystyrene or nitrocellulose, it's coated with a mixture of autoantigens. Then any anti-nuclear antibodies present in the patient sample attached to the autoantigens are then again they're detected by this detection antibodies that provide a readout of the ANA concentration. So readout can be generated by either you link it with an enzyme that produces a colorimetric signal, which is called as enzyme-linked immunosorbent assay, there's ELISAs, or with the fluorescent signals, which we call it as FEIS or fluorescent fluorometric enzyme-linked immunoassays in the presence of a particular substrate. Alternatively, you have a chemiluminescent signal in the presence of a particular solution that is called as CIAs or chemiluminescence immunoassays. So I wanted to bring these terms for those of our physicians or clinicians who have joined as to what exactly it means. Although some of the lab doctors must be very well aware of this. So I apologize if this is a repetition for you guys. Now, so there are multiplex immunoassays, which are line or dot plot assays, or laser bead immunoassay, or ALBIA, or PMAT assays. What are these? So autoantigens are typically immobilized as a line or dot on the cellulose membrane, and the autoantibodies bound to those are detected with the colorimetric signal, enzyme-linked one, with the detection antibodies attached to it. And they are either used typically by a flow cytometric based system using lasers, that is ALBIA, or you use LED based camera system for PMAT. And these are the further two examples of multiplex assays with different autoantigens coupled for different beads for albia and particles for PMAT. This is some of the terminologies you need to know when you read ANA reports. So this is a diagrammatic depiction of the same, where this is a solid phase which is coated with the autoantigens and patient sample binding to it, detection antibodies, and this is either the fluorescent or the enzyme linked tag to it. And in case of a dot or line blot, you see in a single line it comes, and in terms of particle based, you see with albia or particle based assay like that, either by a laser or by light emitting or LED based camera system. Okay. So next we come to the patterns. This is very important for clinicians. So we have the following clinically relevant patterns. So homogeneous, which you see here, A, which is entire staining of the entire nucleus is diffusely stained. Okay. Then speckled, either fine or coarse speckles is seen throughout the nucleus, if you see here. Okay. And centromere pattern, 30 to 60 uniform speckles distributed throughout the nucleus. This is a typical speckle pattern. And nucleolar, where the homogeneous or speckled staining of the nucleolus. Okay, that's within the nucleus. So each of them have their own clinical significance, which I'll come to shortly. So a typical example of a homogeneous antibody would be anti-dsDNA, anti-double-stranded DNA antibodies. So which is found in systemic lupus erythematosus, drug-induced lupus, primary Sjogren's syndrome, scleroderma, and rheumatoid, as well as other non-rheumatic diseases such as Hashimoto's, primary biliary cirrhosis, autoimmune hepatitis. So examples of fine speckled are Rho60, La antibodies, the SSB antibodies, anti-topoisomerase or anti-SCL70. Then some of the myositis-specific antibodies such as Me2, Cu, TIF1, and MDA5. And diseases associated are lupus, Sjogren's syndrome, polymyositis, dermatomyositis, and rheumatoid. And coarse speckled examples are Smith antigen, then U1RNP with SLE and mixed connective tissue diseases, main one. So if you see, there are quite a few staining patterns associated with SLE, which is somebody has raised a hand. So would be good if I address at the end because it just blocks the flow. So you see that you have homogeneous pattern with SLE, then you have fine speckled, coarse speckled. So there are quite a few patterns in lupus. Whereas if you see in terms of mixed connective tissue disease, you probably see only coarse speckled with RNP antibodies. So some are, quite variable in pattern, some are quite unique. The nuclear are mostly is overlap diseases and scleroderma, that is polymyositis and scleroderma overlap with PMSCL75 and 100, U3 RNP known as fibrillarin, RNA polymerase 1, 2, and 3, especially with scleroderma, are found especially with kidney disease, and anti-topoisomerase 1 or SCL70. So diseases associated typically are lupus, rheumatoid, Sjogren's, systemic sclerosis, poly and dermatomyositis, mixed connective tissue diseases. Centromere antibodies are unique for limited cutaneous sclerosis, where you often see skin thickening up to the elbows and knees with prominent Raynaud's, pulmonary hypertension, very less ILD, and most of them have reflux disease or dysmotility as well. Then we come to the cytoplasmic fine staining. So cytoplasmic, we mostly have the histidine tRNA synthetases and all the 7 types of that. We have RNP antibodies, that is ribosomal P proteins, which are RNA protein antibodies, Rho52 SRPs. So we see typically in cytoplasmic staining antisynthetase syndrome with mechanic hands, interstitial lung disease, polymyositis typically, and lupus, Sjogren's and necrotizing myositis. So if you're suspecting anybody with myositis, you definitely need to ask for cytoplasmic staining That's very, very important if the lab doesn't report it. Because in a nuclear, if just they look at the nucleus, typically it comes as negative. Okay. So this table very nicely says autoantigens and immunofluorescence patterns of ANAs associated with rheumatic diseases. So these are the diseases columns, and this is, you have the immunofluorescence testing and cytoplasmic staining. So if you look at the ANA, which is uh, the DNA antibodies or the single-stranded DNA antibodies, there's no specific associated with that, frequently negative in immunofluorescence and cytoplasmic as well. Histone if, antibodies you see in drug-induced lupus, lupus, GIA, you have a homogeneous immunofluorescence pattern, and cytoplasmic staining, you don't see anything. Whereas in Rho, that is SSA and Rho 60, typically you see in Sjogren's and lupus, fine speckled. Sometimes you can be easily missed in the immunofluorescence, and cytoplasmic usually doesn't stain. In Rho 52, of course, you associated diseases are Sjogren's, lupus, myositis, systemic sclerosis, and other autoimmune diseases. You see frequently that its immunofluorescence is negative, cytoplasmic, you don't see any staining as well. U and RNP, large coarse speckled, seen in lupus and mixed connective tissue disease, and with not much or nothing of cytoplasmic staining. This we don't see very significantly. We don't ask this antibody clinically, is not relevant. Now coming to lupus, you see, you can see double-stranded DNA. You can see Smith antigen, ribosomal P, and PCNA antibodies. So you see varied patterns, homogeneous, large or coarse speckled, or you might not see if it's a ribosomal P antibody involved in pathogenesis. You might not see on immunofluorescence. That's where the importance of cytoplasmic staining, which is this column is cytoplasmic staining. So you see a dense fine speckled, which often can be missed if cytoplasm is not looked at. And in systemic sclerosis, topoisomerase is seen in mostly diffuse cutaneous sclerosis, and centromere pattern is seen in limited cutaneous sclerosis. All of them are detected in immunofluorescence. RNA polymerase 3 is seen as large coarse speckled, and fibrillarin in nucleolar mainly, and clinically important ones are RNP antibodies, again large coarse speckled. So none of them typically have any cytoplasmic staining associated with that. And Sjogren's, that is La antibodies, that is SSB, fine speckled on immunofluorescence. Moving ahead, overlap syndromes, you see fine speckled mostly with scleroderma myositis overlaps, and sometimes you see homogeneous nucleolar as well. In myositis or inflammatory myopathies, especially with all the tRNA antibodies, the 7 of them, the JO, and even the associated antibodies such as Me2, MDA5, TIF1, and XP2, most of them doesn't pick up on immunofluorescence. Only Me2 is seen on immunofluorescence, and TIF1. The others, you will have to look for cytoplasmic staining. So hence, if not seen on cytoplasm, if not looked for in cytoplasm, then you easily missed. Okay. And the other reports we often see is DFS 70, which is quite rare in ANA associated rheumatic diseases, but sometimes you see it in reports. And mostly clinically, they don't mean anything because patient won't have much symptoms with that. So I don't diagnose lupus or any other connective tissue based on that. So what is a proposed testing strategy? An optimal test approach to is disease dependent. For lupus, an ANA titer of 1 in 80 on Hep2 cells immunofluorescence, or an equivalent positive test at least once, so is important even in the past. For Sjogren's, solid assays are very good, and in fact can be directly performed, it says, without the need of immunofluorescence. So ideally, I would combine, both immunofluorescence and solid assays for any connective tissue diseases. That's what I would do. For systemic sclerosis, immunofluorescence is good, which got very high sensitivity. Centromere pattern is very highly associated with limited cutaneous sclerosis, and the nucleolar pattern as well. So these two patterns you have to look out for in your reports. And sometimes I go back if I missed in the history taking about Raynaud's phenomenon, skin thickening, skin tightening, and patients come out with that. Okay, so other systemic sclerosis antibodies include fibrillarin, PMSCL overlap, NOR90, which all produce a nucleolar pattern. We can use, none of the existing solid assays is able to detect any of this. So immunofluorescence for overlaps is quite important. Okay. For myositis, we always recommend actually ask for solid assays as well. For example, using dot blot or line blot, high level of clinical suspicion of autoimmune myositis. So it's disease dependent, friends. So approach this again, table says that to ANA detection in ANA associated rheumatic diseases. So in SLE, immunofluorescence high sensitivity, low specificity, combining immunofluorescence with solid assays adds to the value. So we've already dealt with that. What are the staining patterns? Homogeneous, fine speckled, coarse speckled. Any of these can be shown in the reports, and cytoplasmic dense as well in terms if there is ribosomal P. Okay, and Sjogren's. You can directly go for solid assays as good sensitivity and without the need for immunofluorescence. You often see in immunofluorescence nuclear fine speckled and typical antibodies in solid assays, which you see are Rho and La antibodies. Systemic sclerosis, typically immunofluorescence is quite important. So I would certainly ask for it. And most of these antibodies, centromere, then anti-topoisomerase, are detected in immunofluorescence. So I would go for it, especially with the overlap diseases. Okay. So myopathies, as I already told you, it's important you definitely ask for cytoplasmic staining because only a couple of them show up on the immunofluorescence, which is nuclear, that is Me2, TIF1, then other myositis associated and specific antibodies. Mixed connective tissue disease definitely is shown up on immunofluorescence assays as RNP antibodies, which is showing up as nuclear, large, and coarse speckled antibodies. So, importance of each antibody in ANA profile. There's several uncertainties. So, is double-stranded DNA antibody depending on the DNA sequence or structure, and are all DNA antibodies are pathogenic? So these are the questions which are unanswered. I do not have answers for that. Then antibodies that recognize RNA protein complexes or RNP antibodies, it's called. Usually are sometimes, usually they are seen in, ENA tests or ANA profile tests. And you can't see them on, ANA immunofluorescence when you do. So ANA profile becomes important in identifying these, and classic example of that is ribosomal P antibodies. In addition to Smith and RNP anti-RNP antibodies, it also covers Rho and La, that is SSA and SSB. So in terms of SLE classification, Smith antibody definitely is used as a marker, for the diagnosis of lupus. And so DNA and Smith are certainly included in the diagnosis of lupus, and anti-ribosomal P, which usually does not show an immunofluorescence. You have to ask for ANA profile in them, then you will see these antibodies. But they are not a part of the classification criteria, and it has a wider distribution among other diseases like Sjogren's, systemic sclerosis, mixed connective tissue disease, and rheumatoid. So anti-RNP antibodies and Rho 60 are important biomarkers for, in terms of lupus, but they're not specific for lupus as such. And anti-RNP antibodies are commonly expressed in lupus, whereas Rho and La sometimes predates autoimmunity. You see that very early, even before symptoms come, and cytokine release happens. So clinical history is very, very important. And that's the reason, if you see that this is the new classification criteria, which is the ACR EULAR American or European classification criteria. So they have said that ANA titer of 1 in 80 on Hep2 cells are equivalent ever is entry criterion actually. And if absent, do not classify as SLE. If present, apply additive criteria. So additive criteria they've actually given in terms of weightage, fever, then you have leukopenia, thrombocytopenia, neuropsychiatric symptoms, and of course in immunological pattern of other antibodies such as APLA, complements, and SLE specific, which I told about DNA and Smith. So SLE classification criteria requires one clinical and at least one clinical criterion, and you need to score more than 10. This, of course, was designed more for trial purposes. They are not for diagnosis, but it helps you in keeping in items which you might help for you to consider for diagnosis. And separate points are given for alopecia, mucocutaneous ulcers, discoid lupus, and serositis. So, in just not just the test, you need to look at several other clinical features, including urine test. Urine test is the earliest sign of kidney disease, where you're having a protein of 2 plus and above, and then you quantify by doing a protein creatinine ratio to start with, or even a 24-hour urine test. And of course, if they're abnormal, then you go for biopsy, and that is definitive evidence of lupus or not. So this pretty much applies to almost all connective tissue diseases. That's where the first slide I took time in describing each disease. And this slide tells us about the importance of several antibodies in SLE patients. You see that 96% of them, in lupus, prevalences of these antibodies in 96%, anti-DNA, dsDNA antibodies 78%, and followed by ROLA, RNP, Smith, rheumatoid factor, loop, and APLA, and so on and so forth. So what do I need from a report? So I need a start dilution, and I feel that 1 in 100 is a good starting point, because the lower you go, you accumulate a lot of nonsensical diagnosis comes in play. And an endpoint titer of at least 1 in 160 is where I found clinically meaningful. 1 in 80, sometimes, you do pick up things which are not clinically significant. And any strength above 2 plus, is actually meaningful for me clinically. And pattern, I already told you, those tables are very helpful in terms of lupus has a multitude of patterns. Scleroderma has 1 or 2 patterns only. So patterns are quite important in terms of that. So the important message is never do an ANA test if you don't think clinically you're suspecting an autoimmune rheumatic disease. And always combine the test, immunofluorescence with solid assay. Always look for an endpoint titer, staining pattern, and strength. And do not use ANA to monitor the diseases. And please do refer to rheumatology or immunology, because all the fallacies and nuances can be easily picked up. Unnecessary diagnosis will increase anxiety to the patient and unwanted immunosuppression. Thank you very much.
Yeah, so with this, we thank Dr. Vijay for such a enlightening and a wonderful talk on ANAs. Like, I think, as I told you, that no autoimmunity seminar is complete without ANA. So maybe it's a routine test for autoimmune diseases, but still, as Dr. Vijay has told us, like before we started the webinar, he told like the most used and abused test is ANA in autoimmunity. Yeah, fine. Thanks for such an enlightening talk. So we'll take question and answers at last. So if anybody who has question, we have a box, QA box on the screen. They can put their questions there. We'll take both the questions at the end for both the webinars, like other one also, because we are already we're late, we're behind our time. So we'll start with the second session of the day. That's from Dr. Savino. He will be talking about, I think Dr. Savino can share the screen also. So Dr. Savino, he will be, like yesterday also we had a talk on APS, that is antiphospholipid syndrome. So today, Dr. Savino, who is MD, PhD, he will be working at the Center of Research of Immunopathology and Rare Disease, the University of Turin. It's in Italy. So his special interest and main focus is on autoimmune and rheumatic diseases, and with a particular interest in APS, that is antiphospholipid syndrome. There are many papers, more than 150 publications, and he's gone as a speaker in many international and national congresses of autoimmunity and many conferences. And he will be telling something to us about the novel biomarkers in APS. So over to you, Dr. Savino.
So good morning or good afternoon to everyone. It's really a pleasure for me to be here with you. I have just to start with a sincere thank you to Verfen to organize this opportunity to share some thoughts to Dr. Lal and to Daniele Yellow and to all of you and to the previous speaker who started this meeting in such a nice way. So the idea of today is just to share with you some thoughts about the diagnosis and the classification of antiphospholipid syndrome. And the previous speaker has mentioned that ANA tests are still a kind of mythological entity. And I would like to share these thoughts also about antiphospholipid antibodies. There is a solid knowledge about these antibodies, but a lot still have to be done. So what we know about the antiphospholipid syndrome? I would like to start with the idea that this is a very recent syndrome. It's been described probably in the early 80s, around 1983, when Professor Hughes in London had the idea of putting together some clinical manifestation in some patients, mainly thrombosis and pregnancy morbidity, in some surgery were presented what they call at that time preliminarily antiphospholipid antibodies. Since then, and after almost 40 years from the first description, a growing body of evidence has improved our knowledge about this syndrome. And now we know that it is probably the most common acquired thrombophilia with some peculiarities. The first peculiarity is that probably is the only case in which thrombosis might affect both the arterial and the venous system. And this is a quite peculiar characteristic of this syndrome, because, for instance, all the inherited thrombophilia that we might mention basically affect only the venous system. Another characteristic of this syndrome is that it's probably responsible to up to 20% of recurrent miscarriages in early women. And we don't have to forget that this is a high, a very frequent cause of disease, especially in young people when thinking about cerebrovascular event. And that it has been estimated that probably up to 1 out of 5 strokes in young people aged younger than 50 is probably due to the presence of these antibodies. And then we will talk briefly a little bit, probably one of the most clinical challenge situation, which we are all aware that probably up to 40% of our patients with SLE might be positive for antiphospholipid antibodies, but not all of them are going to develop the clinical manifestation. So this is one of the key points that we are going to discuss a little bit further. Since the first description, as I was mentioning, our understanding of the syndrome has changed. And now we know that what we can collect to the presence of the antiphospholipid antibodies goes far beyond thrombosis and pregnancy morbidity only. But we have a constellation of different clinical manifestations to include neurological, such as headache, chorea, cognitive disorders, hematological, such as low platelet or hemolytic anemia, but also cardiovascular to include heart valve lesion and pulmonary hypertension that are all related to the presence of antiphospholipid antibodies. So one key point that I would like to stress that don't think about testing for antiphospholipid antibodies only when assessing a patient for thrombotic and pregnancy morbidity, because a constellation of other clinical manifestation, what we call now the extra criteria manifestation, can be also due to this patient, to the presence of these antibodies, especially in patients with lupus. This is a very complex clinical situation, and when we are facing such an heterogeneity, usually the international societies, such as the International Society of the Antiphospholipid Antibodies, but also the EULAR and the ACR, propose some classification criteria. As was previously said, classification criteria are not meant for diagnostic purpose, but they can come very handy when we are thinking about that. So they might not cover all the situation, but definitely might help us in guiding our suspicion. So the first set of classification criteria for APS was developed back in the 1990s when the presence of vascular thrombosis, pregnancy, morbidity, and the presence of at least one out of two antibodies that were better described at the time, which are lupus anticoagulants and anticardiolipin antibodies, were sufficient for the diagnosis of APS. So the diagnosis of APS, according to the classification criteria, was basically based on two pillars: the clinical pillars, so the presence of thrombosis or pregnancy morbidity, and on the other side, the laboratory part. And the laboratory part was basically, in the first description of the criteria, based on lupus anticoagulant, which is a functional test, an hematological test, and the presence of anticardiolipin antibodies. And these are to be repeated at least in two occasions, 6 weeks apart. And this is to reduce the number of false positive tests. Later on, the criteria were updated, and this is still the last update of the criteria that we are using in research, in clinical research, when thinking about the antiphospholipid syndrome. And those are the so-called Sydney criteria. There are no big changes apart from two main items. The first one was the addition of a new antibodies in the laboratory pillars of the criteria that were the anti-beta 2 GP1. So the first big changes is that, and that they increased the span between the two repetitions of the test up to 12 weeks. And this again was meant to reduce the level of false positive tests, because we know that a number of different situations, including infection, might cause positivity, temporary positivity for antiphospholipid antibodies. And when we are thinking the true antiphospholipid syndrome, these antibodies are usually permanent and persistent over time. So wrapping up the idea of classification criteria, at least with what we have so far, is one clinical pillar, thrombosis and pregnancy morbidity, in patient who has been persistently tested positive for antiphospholipid antibodies. And which are the tests that are currently included in the classification criteria? Those are lupus anticoagulant, anticardiolipin antibodies, and anti-beta 2. And they have to be tested positive at least twice, 12 weeks apart. And so this is what we use now for clinical research in APS. What I want to share with you is some thoughts that how we can go beyond the classification criteria in order to improve the management of our patient also in the daily practice. Why we need that? Because for any physician, any person working in a healthcare provider, we know that thrombosis is a very frequent problem. And on the other side, we know that just a small percentage of these patients might be tested positive, presenting with what we call the clinical manifestation of thrombotic APS. On the other side, we also know that pregnancy morbidity are very frequent, but not all the women with pregnancy morbidity have APS, just a portion of them. If we increase the idea that the clinical manifestation of APL related can be even going beyond thrombosis and pregnancy morbidity, we understand that we are really challenging a situation in which we really have to rely on good performing tests in order to screen all this complicated clinical heterogeneity. So the key point of this talk will be how good are we now in 2020 in identifying and using as a proper prognostic and diagnostic tool the antiphospholipid antibodies profile. In an ideal world, we will have just one test with 100% of sensitivity, 100% of specificity, and this will be the perfect ideal diagnostic tool to discriminate among all the heterogeneity situation that I've been sharing with you in the previous cartoon. Unfortunately, we are far from that, and this is most likely how the situation appear in the clinical setting. We have patient with thrombosis, patient with pregnancy morbidity, patient with other autoimmune disease such as lupus who might present with antibodies, and we need to critically examine our IPL profile in order to have informative and critical data to guide our interpretation. So basically, I want to discuss with you two main things. which are the new tests going beyond the the tests suggesting the clinical criteria. And I want to stress another idea, that we need to use those tests for risk stratification. And we have to go beyond the idea that antiphospholipid antibodies are just a biomarker of a disease. How these ideas has been developed. If we look back at how the first antiphospholipid antibodies has been described, we go back that the first test who has been described was the lupus anticoagulant. As you probably know, this is a functional test. It's a modification of a prolongation of the APTT, in which we notice that the presence of the antibodies might interfere with the coagulation test. We don't know which antibodies are we talking about, but we notice a functional prolongation of this test. Along with the time, we understood that these antibodies were probably antibodies were interfering with protein binding the membrane of these antibodies. The first one who has been described was the anticardiolipin antibodies, first from bovine source, then from human source. But the story of APS didn't stop there, because now we know that antibodies binding the human cardiolipin are probably directed to a protein which is part of this complex, which is the beta-2-GP1. And I will share with you in a few moments that the story has gone even further, that the bad antibodies, which are those probably responsible of the clinical manifestation of this syndrome, they don't bind all the molecules, but just some molecular domain of it. So this is the story of the APS. We start with the functional test, and then we are, along that, improving our diagnostic accuracy, going to the molecular specificity, who are probably responsible for the clinical manifestation. And why this is important? This is important because looking at the profile will help us to identify those patients who are more likely to develop the clinical manifestation and eventually start primary or secondary thromboprophylaxis for those patients. So use these antibodies as a risk stratification tool. In the last 10 years, has been this, several new antibody specificity has been described in the field of APS. For the purpose of this talk, I want to share with you some thoughts about two of these family, the anti-beta-2-GP1 domains antibodies and the anti-prothrombin antibodies, because these are those families of antibodies on which we have more supportive data, and eventually to support them, not just in a research setting, but also in a routine clinical use. I want to start with some ideas about the anti-beta-2-GP1 antibodies. As I previously mentioned, in the CNA criteria, in the 2006 updated classification criteria, the presence of anti-beta-2-GP1 domains was added among the laboratory criteria for APS. Those antibodies were binding the molecules, but we didn't know at which part of the molecules these antibodies were potentially interfering with. What we know now that not all the antibodies binding the beta-2-GP1 are equal, because now our knowledge about this molecule is improved, and we know that this molecule is constituted by 5 different domains. The domain 4 and 5 are probably those binding the surface of the cellular, while the domain 1 is those standing up in the bloodstream. And now we understand that different antibodies might bind a different part of the domain with different specificity for the clinical manifestation. And this is a crucial point, because this might at least partially explain why some patients with these antibodies, anti-beta-2-GP1, might have clinical manifestation while others don't. So I'm referring here from some data about the Milano group, and the leading author was Laura Andreoli. What she did, she tested for different, she took from her cohort all patients positive for anti-beta-2-GP1 antibodies, and then she tested her cohort according to the different antibody specificity, dividing what patients were positive for anti-domain 1 and what patients were positive for different antibody specificity. And what she found that those patients with clinical APS, which means patients who suffer for vascular and obstetric APS, were those in which the anti-beta-2 GP1 domain 1 were much higher in titers. On the other side, APL carrier, which are patients positive for antibodies, but no previous history of the clinical manifestation, were positive for the domain, for the antibodies recognized in the domain 4 and 5. Why this is clinically important? Because this might guide us in treating different patients according to their antibodies profile. Because we know that antibody recognizing the domain 1 of the beta-2 GP1 domain are those with the bad antibodies, the pathogenic antibodies, those who are more probably linked with the clinical manifestation, those associated with the high risk. On the other side, those patients, even testing positive for the all molecules of beta-2, but they are positive for domain 4 and 5, those patients are less likely to have the clinical manifestation, and they have a low risk profile. And this might guide us in how aggressive we should be in terms of antithrombotic therapy, especially in thromboprophylaxis. And this might explain why we have a huge heterogeneity among what we call positive APL patients. Now we are starting to look into subpopulation of antibodies, and introducing the difference between domain 1 and domain 4 and 5 might help us in the future to treat this patient differently, because patients with anti-domain 1 are those with high risk and a stronger association with vascular and obstetric manifestation. Those with positive domain 4 and 5 are low risk, and those antibodies are more frequently found in APL carrier, which are patients positive for APL, but no clinical manifestation. And we confirmed recently in a systematic review those observations showing that patients tested positive for domain 1 antibodies are those with higher risk for the clinical manifestation of APS with a high level of overall statistical significance. And this is another key point to challenge our clinical practice, because it is common practice for those taking care of these patients to find a patient with APL positivity, either beta-2 or anticardiolipin antibodies. Testing for these new antibodies might guide us in assessing the risk of the patient that we are taking care in that moment. The second family of antibodies that I would like to share some thoughts with you about are the so-called antiprothrombin antibodies. Now we know that prothrombin antibodies are a family. They can be tested in different ways, and basically the tests that we have more information about are antiprothrombin antibodies tested on irradiated plate, or antiphosphatidylserine prothrombin antibodies, antibodies recognizing a complex, usually tested on not irradiated plated. And even though these antibodies can be found positive in the same patient, we know that these antibodies don't have the similar sensitivity and sensibility for the clinical manifestation of the syndrome. In fact, when we pulled together back in 2014, more than 6,000 patients and 1,400 controls tested for antiprothrombin antibodies, we found that even both these antibodies might be found associated with the clinical manifestation of the syndrome. The association was much stronger with antiphosphatidylserine and prothrombin antibodies. So this is another tool in which increasing the information of our APL testing may be crucial, because these antibodies might be crucial when APS is suspected, clinically suspected, but other antibodies are negative, or when we want to assess the risk of a patient, following the idea that higher is the number of APL specificity positive, higher is the risk for that patient. So with a number of antibodies possibility for be tested when APS is suspected, one question might rise. So do we really need more tests, or a better use, a better combination of the tests that we have? And this is the question that we tried to address when I was working in London with Professor Camasta and Dr. Bertolaccini, trying to combine with a kind of lottery system the different antibody specificity, looking for which is the best combination to win the lottery of APS, which is the best combination in terms of sensitivity and specificity, using a different combination of 3 or 4 tests take into account the antibodies profile that we were available. And so this is the ROC curve summarizing together sensitivity and specificity. And then we know that more the curves approach the upper left corner of the figure, better is the test. What we found combining different combination is that the association of using the combination of lupus anticoagulant, anti-beta-2, and APS-PT, phosphatidylserine and prothrombin antibodies was the combination of tests with the best clinical and diagnostic occurrence for both thrombosis and pregnancy morbidity in APS. And if you think critically, this might be not surprising because we know that lupus anticoagulant is a functional test, and the presence of lupus anticoagulant has been associated both to the presence of anti-beta 2GP1 antibodies and antiprothrombin antibodies. But as I briefly mentioned at the beginning of this talk, I said that now we know that truly antibodies recognizing the anticardiolipin antibodies are those interfering with the beta-2-GP1 complex. So in some point, testing for beta-2-GP1 might also be informative on the presence of the true and the pathogenic anticardiolipin antibody. So adding another antibody specificity, such as the antiphosphatidylserine prothrombin, might not be surprising because in this way, we cover both the pathogenic pathway that might be related with the clinical manifestation of this syndrome. So at least in our hands, and this information has been confirmed in different studies since the first description in 2012, adding this combination of tests might have probably the best clinical accuracy, even beyond the combination of tests suggested by the Sydney classification criteria. Now that you know a little bit more about the main character of the upcoming scenarios of APS, I want to introduce you and share some thoughts about I think the real new frontier of the antiphospholipid antibody syndrome, that is the risk stratification. For so many years, we have thought and we have looked at the antiphospholipid antibodies as we have a patient with thrombosis, we have a patient with pregnancy morbidity, we test for these antibodies. If the test is positive, the patient might be classified as having APS. If the test is negative, the patient has no APS. I think that this idea does not apply the new frontiers of medicine. This is too far. This is when patient has already had thrombosis or pregnancy morbidity. We have to go beyond that, and we have to look into the eyes of our patient with APL positive test and start considering this as a risk factor for both thrombosis and pregnancy morbidity to avoid those patients to have future thrombosis or future pregnancy morbidity event. So to treat this as we treat cardiovascular risk factors, smoking, hyperlipemia, don't wait for the clinical event to happen. And this is very true in patients with already an autoimmune disease that we might allow and suggest the screening for different antibodies. I want to share with you 3 different clinical scenarios, and these are real patients for everyday clinical practice. The first one is a female, 35 years old woman. She was only anticardiolipin antibodies, and she was tested because of her underlying lupus with mainly skin and joint involvement and mitral valve involvement. Another patient was a young boy, 24 years old boy. She was positive only for lupus anticoagulant. It was tested because a strong levator reticularis, and his clinical history is just positive for arterial hypertension with no concomitant rheumatic disease. And the third one is a young lady of 22 years old. She was triple positivity, and she was tested because of a prolonged APTT with no other medical history. So when you attend this kind of patient, in our mind, these are the questions. Who is going to develop a thrombosis? How we can prevent this thrombosis? Or even more critically, as we know that stroke is very common among patients tested positive for antiphospholipid antibodies, who is going to develop a stroke? Or for instance, who is going to develop one of the extra criteria clinical manifestation of this syndrome, such as APL nephropathy? With how we stand now, these questions are still unanswered. We still don't know who and how far in the future this patient might develop the clinical manifestation. And to try to attempt this, the Euler recommendation stress the idea that we need a risk stratification tool. What they show that high risk patients are those with lupus anticoagulant or double positivity or triple positivity. The good point of the Euler recommendation was the fact that they stress the importance of risk stratification. But from the clinical point of view, this information is still not very informative, because we all know that being positive for double or triple or just lupus anticoagulant identify a big group of patients within which we might still have some heterogeneity. So we have to go beyond this idea and what we can do. For instance, these are the data from Professor Pengo in Padova in the Northeast Italy, showing that we know that patients with more than one positive test are more likely to develop the clinical manifestation of the syndrome. And we know that what we call the triple positivity identifies patients with high risk of thrombosis. What we don't know and what we cannot answer is when the risk is high enough to start antithrombotic thromboprophylaxis strategies. Because now it's not enough to say to a patient that, oh, you are at high risk of thrombosis and not act accordingly. But the patient might ask you, when my risk is high enough to put in practice some therapeutical strategies. And so far, we still don't have a tool in which we can compare the risk of different patients, which means how we can compare oranges with oranges, avoiding to pull together patients with different risk of thrombotic. And the first attempt in this term was performed by the Japanese group. The first author was Otomo, with the idea of performing and introducing an antiphospholipid antibody scoring system. They tested a big cohort of patients with autoimmune disease. They included criteria and criteria antibodies, and then they weighed each variables according to the strength of the risk association. The pros of this study was the fact that they pushed the idea of the need of a scoring system in APS. Secondly, they went beyond those tests that they were suggested only in the classification criteria, introducing the APS-PT that, as I briefly showed you in the previous cartoon, are strongly associated with the clinical manifestation of the APS. This study has some cons, because probably this is the perfect tool in a research setting, but in the everyday clinical practice might be a little bit tricky and time-consuming to use. And secondly, it might suffer for some heterogeneity between one and the other. Taking the Japanese experience and with the idea of making one easy tool to including the cardiovascular risk factor, back in 2016-17, we developed what we called global APS score, with the idea of having a tool fast to use that cannot take more than 5 seconds to be calculated, including criteria and extra criteria APL antibodies, but also cardiovascular risk factor. And those manifestations in terms of cardiovascular risk factor who found strongly associated with the thrombotic risk in the validation and in the developing cohort was hyperlipidemia and arterial hypertension. So mixing together this information, we found we proposed a developing scoring system in which adding together the point of each patient may help the physician to quantify the risk of such patient. Nowadays in medicine, we are very used to use quantification scoring system, but the field in APS was still lacking of one of those. And since the first description, this is just a table summarizing it, we have probably some thousand of patients in which the global APS score was used and validated, and all are in line showing that higher the score, higher the risk. And if you want a number, usually every scoring system beyond 10, so when the gaps score 10 or more, those are the patients in which the first event or a recurrent event is more likely to happen. So how we can improve, and this is one of the last ideas that I want to share with you, how we can improve the management of our APS patient. If we want to aim to pure feasibility, we have the classification criteria. They are good, They are easy to use, but they don't give us information about the risk of the patient, and they don't include the new antibody specificity. On the contrary, if we want to be very accurate, but probably more in a research setting rather than in a clinical setting, we can use the APL score proposed by the Japanese group. What we think is something in the middle with an acceptable feasibility and good specificity is the global antiphospholipid score, who combine pros and cons of the Sidney criteria and the antiphospholipid score with the idea of adding together also the cardiovascular risk factor that we know are important risk factor in identifying which patient tested positive for APL might develop the future manifestation. And my hope for the future in the field of APS is that probably in the next meeting, next year or whenever it will come, we won't talk about APS per se, but we will have more information starting from the APL profile, but also from new technique, and for instance, the PMAT has been previously mentioned, that might help us in identifying different phenotype of patient, starting from a common clinical setting, potentially guiding the treatment, because we know that some patients with APS may go well with just one thrombotic event and then stay free from disease the rest of their life. Some patients might have recurrent disease, and still we don't treat this patient in a different way. The aim will be to use the lab to improve our clinical management. And with this, I thank you all.
So with this, we thank Dr. Savino for such a nice talk, such a wonderful webinar presentation. Everything was so beautiful. So now we go to the QA session. So the first question is for Dr. Vijay K. R. Rao. Sir.
Hello?
Yes, sir.
Yeah, so
Mhm.
this is in the Dr. Haresh Jumani, isn't it?
Yeah, yes, sir. It's with Dr. Haresh Jumani. He wants to know that many times he gets ESR in high, like 90s, but patient is asymptomatic. Later, after many years, some symptoms start coming up, for some autoimmune disease. Like, what will be the test after having a high ESR in asymptomatic patient?
I wouldn't do any test. I mean, just because of high ESR, I would probably tell the patient, educate the patient to look out for symptoms of inflammation, that is stiffness, morning stiffness, stiffness related to rest, small joint pain, or even back pain, and so on and so forth, and leave it at that. I would look for other causes of raised ESR, such as if there's an infection or something like that. But specifically just for symptomless patients, for just on ESR, I wouldn't do an autoimmune screen. That's my practice. I don't do it.
Okay, so the second question also is for you only, sir. It's for, I think, Dr. Harjot Singh. He wants to know there are 50, regarding a 50-year-old female.
Okay.
ANA on ELISA positive, IFA titer increased, anti-SSA titer quantitative increased, was on hydroxychloroquine 200 mg since 3 years, got an anti-CCP done. CCP is more than 200. So now he wants to know what he should be making out of this CCP antibody positivity now.
Okay. So main thing here is I would rely on symptoms. So I would go, what is the dominant symptom here? So dominant symptom, if it is inflammatory arthritis resembling a rheumatoid, then this is a primary rheumatoid with secondary Sjogren's. But if the dominant feature here is a Zika symptom, that is with dry eyes and dry mouth, excessive fatigue, and with more of polyarthralgia than polyarthritis, then I would probably call this as primary Sjogren's only. Don't make your diagnosis just based on CCP antibody. I'll give you an example for this. I often have realized more and more patients with psoriatic arthritis and ankylosing spondylitis clinical features. That is, they have band or back pain, they have sacroiliitis and MRI, And just because another clinician has done CCP is about 200. It is not rheumatoid. It's all about rheumatology's clinical manifestations. That's very, very important. And the previous speaker very nicely said that the fallacies of antiphospholipid is that, I mean, just because of negative antiphospholipid test, we say that, patient does not satisfy the criteria, but the important is risk factor, and what their proposed strategies they're doing is just amazing. It's important about what your patient has. That's the main thing. So I wouldn't rely too much on what the test is showing. I would go on the symptom manifestation. I think this is a continuation which says very much specific will develop full features. So I would certainly look out for, because with high CCP titer, you can educate the patients and also say that you might develop more of hand disease or fit disease and more of RA site of symptoms. So your therapy should be more based on addressing the arthritis part. So choose an agent which works very well for joints, such as your methotrexate works very good for joints. Your tacrolimus works very good for joints. I would choose one of those. I think the first two tests have answered questions.
Okay.
So third one is probably for Dr. Savino.
I can take care of the third one. Thank
Yeah,
you.
third one.
And
Yeah.
I think that the situation might be a little bit, the question is about the availability of the new tests that we have been discussing together, like the beta-2-GP1 domain 1 or the APS-PT. I think that the situation is rapidly evolving. Might be difference in terms of globally, but what I can say that, for instance, APS-PT are available in ELISA kit, and anti-domain 1 are available in chemiluminescence testing, and both they will include in PMAT testing. So this might be different from country to country in terms of when they will be available, but the situation is moving fast, and in some countries these are just already part of the clinical practice. So I would expect them to be available globally very soon, but probably this distributor might be more helpful in terms of timing. But this is not just something happening in research lab, but this is something that is happening also in the routine lab testing. So this is why it's fascinating how the field is moving fast.
Dr. Savino, I wanted to ask about the antiphosphatidylserine antibodies. Is that clinically available?
I mean, the point is that I would say yes for two reasons. If a patient has already the diagnosis of APS with thrombosis and positive for any test, you might not feel the need for a new testing. But if you have a patient, for instance, in which you have a clinical suspicion of APS, like low platelet, radiculoreticularis, young patient with a thrombosis, and you find the screening for the conventional APS negative, this is where I would go for APS-PT testing. Secondly, this might again changing from country to country, but sometimes we have a patient which testing for lupus anticoagulant is not reliable, or you don't want to stop the anticoagulation that is already ongoing with vitamin K antagonist. And in this patient, having more information might be useful. And we recently published that in this subsetting, for instance, testing for APS-PT might be useful, especially when lupus anticoagulant is uncertain, dubious, or not reliable. So how I use APS-PT is basically when I need more information. When the situation is very clear, of course, we don't need more tests. When you have some clinical doubt, this is where I feel that APS-PT might be useful, especially, for instance, in lupus patient with little bit of anticardiolipin antibodies, and you are thinking to start, yes or no, aspirin, for instance, as a primary thromboprophylaxis. If you have another test confirming the APL positivity, this might push you more further in using primary thromboprophylaxis tool. So is all the situation in which I think that where clinical challenge exists, more information we have, and we are able to critical analyze those, this might help us. So not necessarily in already established situation, and again, in line with your previous comment, the clinic has to guide. But in all these situations in which clinic might need some extra information, I think that testing for APS-PT might be a reliable tool. This is what we are using in the clinical practice. And I think that in a good number of patients helped me in taking a more evidence-based decision rather than just my gut feeling.
Okay.
And sir, I think there is one more question for you, sir, from Dr.
Yeah.
Ayush.
So, see, the recurrent mouth ulcers, I would always check for lupus, because in lupus you'll have secondary Sjogren's and with dry eyes and Zika symptoms. If you're really thinking Sjogren's as a possibility, then of course you have to go for, if you're, what I mean by that test comes negative, if you're telling that immunofluorescence, solid assay and ANA profile or ENA is negative, which means you're telling Roux and La is negative, then you'll have to rely on histopathology. Go for a lip biopsy and look for focus score and do for the test of your eyes and your salivary tests. And if you feel that these tests are especially biopsy is suggesting, then it's probably primary Sjogren's. But my gut feeling probably would be with recurrent mouth ulcer, this could be a lupus. Look for lupus antibodies and look more in terms of that. Be very careful about dry eyes. I mean, I've seen many fibromyalgic having dry eyes and Zika symptoms. So where all the antibodies comes back negative. So in which case, the mouth ulcer could be an acid reflux disease, and you have to treat for that rather than calling it any negative lupus or connective tissue disease.
Sir, even I have a question, sir, for you.
Yes, sir.
Sir, actually, you might have seen many of the lab like us also, we do ANA reflex testing. Means if ANA comes positive, we go for blood tests, like ANA profiles. So what do you think those ANA, the positivity of ANA with patterns should be based on clinically we should go for a profile, or depending on the pattern, like we have profiles with, say, nuclear pattern, cytoplasmic pattern, and even nucleolar pattern. Different profile for all these patterns are available.
So if I get your question right, you have to change your pattern based on clinical manifestation is your what asking, or report it as it is?
Yeah, that's what I'm saying, sir.
If you certainly, I mean, at least my microbiologist or histopathologist in Anand lab calls me that I'm not seeing, sir, I'm not seeing anything in immunofluorescence. Cytoplasmic is lighting up. What is your clinical profile? So recently I had a case of necrotizing myositis with anti-SRP antibodies. And, the patient was very, very myopathic, extremely myopathic. And I was pretty much sure that this is a case of, autoimmune myositis. He called me and he said, sir, shall we do a myositis specific antibody? Because, this is looking more like that. So certainly clinical information is very important. But reporting of pattern equally as it is important, because it works either way around. So for me, somebody, let's say you report a nucleolar pattern and a patient comes to me with more of inflammatory arthritis, and I would not have taken, because I see 60 patients a day, and I would not have taken Raynaud's disease. Let's say I'm taking history in a peak summer in India where temperature touches to 50 degrees some places. So patient may not even notice Raynaud's, especially living in South India. And at that time you might miss it. But if you say nucleolar, then I will be looking at, this patient might develop scleroderma features. So, which is the dominant clinical domain. So it works both way. I need pattern as it is, and a lab doctor needs clinical information. Both should marry together.
So what do you think, sir? What are our clinician friends should provide to a lab when they are prescribing a ANA test?
They should give a short history of what are the dominant clinical domains and what is their first suspicion. Provisional diagnosis is important. I always see in any connective tissue disease, what I've learned within Lupus Center of Excellence is I write down clinical domain which is dominant. So even in cases of, let's say, a mixed connective tissue disease, an overlap disease, each presentation I write dominant domain joints, dominant domain lungs, dominant domain skin. Thereby your antibody patterns also varies. So that's, you have to match both. So a brief form, I think you should generate some form as well to actually, brief would be organ involvement, tick, 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 which you have. That makes,
that's a nice suggestion.
Yeah,
it makes more sense.
Yeah, yes, because clinician might not think that. And if the form says that tick all organs involved, then the clinician will think, oh, I have not investigated this.
So we have also Dr. Anand Malvi has also joined us as a panelist now. So I think like in India, there is no one better than him to say anything on ANAs.
Definitely.
So we can call him, I think we can call him father of ANA in India, especially.
Father of rheumatology in India.
Yeah, rheumatology. Yeah. I am more of ANA, no, because laboratory person. No, sir. You guys are rheumatologists. Sir.
Thank you. Thank you for that.
Sir, now we have both you. Like you are here, Dr. Sir is also there. So I want to know, like, why we always take ANA only for rheumatology? Like now we are seeing in many things they are asking for ANA testing, like autoimmune liver diseases, even in OBG, BOH, bad obstetric history panels. They want to know ANAs. And as much I have read, there is always that titer they want, like in gastroenterology and in OBGs, they always want that lower titer. So why should not we start testing for, like you were saying, 1:40 is not significant. It's not significant for rheumatology, but it's significant for maybe a gastroenterology. So what's your thought on that? How does a laboratory person go for that?
Now, I tell you, my take is a bit different. Like we have learned where to order anti-nuclear antibodies. And then you people taught us, the ICAP group taught us that, look, just positivity, negativity, and titer may not be enough. It is the pattern which may really help us guide towards a certain disease. And we have now learned that unless we get the ICAP pattern, we can't be very sure which category of patient are we seeing, especially in early cases with symptoms that are not very specific of any one of the ANA-associated diseases, but it could be the early stage. I think gastroenterologists and hepatologists and others will have to go through that learning phase. And it is not difficult, really, if we start calling them also in such meetings. And they are good doctors, they are intelligent doctors, and they will learn over a period of time what is of importance to them. This is one of the things which I think a sort of a collaboration, that in such a meeting, they should also be invited, that many of the autoantibodies, they may be indicating liver disease and inflammatory bowel disease. So they must join us to understand the intricacies that was discussed by the two speakers. One of the points not related to your question, which I'm very keen to discuss, is many patients, most of them being fibromyalgia or over anxious anxiety neurosis, they go to the doctors and without thinking much, they order so-called arthritis panel. I think ordering arthritis panel has been the biggest bane of investigations. That always leads to some non-specific type of positivity. Then patient starts running here and there and all looking at the different diseases. And finally, they come to us that this titer 1 in 40 ANA is positive. Clear-cut case of anxiety neurosis or fibromyalgia. And you have to then convince them that this ANA has no meaning. And therefore, for me, ICAP patterns, which are seen mostly in normal people, the discussion of that is also very important. And the doctors must be told about the patterns that really are seen more often in normal people than in connective tissue diseases or so-called ANA-related disorders, in which DFS is one of them, which is hardly ever seen in connective tissue diseases. I will like somebody to give us a small list that these ICAP patterns are primarily seen in normal people. Anything else to be discussed?
No, sir, I think you have told everything in such a small time. And I don't see, I just see the question. So this Mr. Haresh Jumani is again asking that Dr. Haresh Jumani, that does lab have ANA profiles? Yeah, we have ANA profiles, but the ANA profiles are not called ANA profiles. They are called ENA profiles. I think sir can tell us better the difference between ANA and ENA. No, sir?
Well, yeah, ANA are the classical old Engtan and Holbrow fluorescence. It was started on rat liver, and then came the HEP2, and now we have even the modified HEP2 where the Rho antigen has been infected in the genes, and now that is the HEP2 that we are using for the substrate. Now that was ANA. But then Engtan from Scripps Clinic, La Jolla, he produced a soup out of cells. And he started using that as the antigen in double diffusion gel diffusion testing. And that's when, while the anti-nuclear and on immunofluorescence, in some of the patients was positive, but when he started using these cell soups, he found that one positive may give several different patterns of antibody. And if you know Octoloni testing, the lines were crossing each other, which means it was not single antigen, but more than one antigen, which was involved in that ANA. So in the olden days, we thought ANA is one thing. It's an antibody against something in the nucleus. But then by using the gel diffusion, double diffusion testing, it became very clear to Engtan that what we are seeing is actually a mixture of antibodies. And those mixtures of antibody and their determination became ENA, extractable nuclear antigen. And then Ravindranath Mani, he came up and he said, well, not really. It is not extractable nuclear, but extractable cell antigen. And he insisted that nuclear is only nuclear, while in immunofluorescence, we can also comment upon the cytoplasmic antigens. And therefore, it should be cell extract from the whole cell. That is what we are studying as ENA. So ANA classically is immunofluorescence, while ENA classically started as double diffusion, and now we have gone to solid phase assays, various types of assays, including ELISA and dot plot and etc. So that is the difference. So further classification of the type of ANA that becomes ENA.
So I think sir has answered it wonderfully well. So I don't think there will be any queries left. I don't see any more queries. So with this, now I request Dr. Vanna Lal, who is our executive director at Dr. Lal Path Labs Limited, for a vote of thanks. Ma'am, over to you, ma'am.
I want to say namaste to her.
Good evening, Dr. Malviya. So nice to see you. You know, you could join us.
Thank you.
We've had a wonderful seminar for 2 days, and I especially want to thank the speakers who spoke today is Dr. Vijay Kumar Rao and Dr. Savino. And we've had a lot of learning experience. And what also we learned is that in spite of being pathologists, we know that we should treat the patient and not the report. This has been a a very, very welcome suggestion given by the speakers today. Thank you very much. Thank you, the WRFN team, and also my own team who have supported this seminar. Thank you very much.
Thank you. Bye-bye.
Bye.
Okay, thank you, sir. So thanks, everyone. Especially thanks to our WRFN team. Dr. Daniele, thanks a lot.
Thank you very much.
Thanks,
to
Bharat.
everybody.
Yeah, thanks.
Hope to organize next year a real live event.
Yeah, of course, it will be real life, and you will be always there as the first speaker for us. Because
well, also we can have Dr. Savino Shasha also in Delhi next year.
Yes.
Yeah, of course, of course.
Will be my pleasure. Thank you.
Okay,
We'll
thank you,
try to have more
everybody.
and more people in this.
Yeah, thank
Okay,
you.
thank you. Thank you, Dr. Savino. It's nice.
Thank you. Thank you, everyone.
Thanks to all. Yeah.
Thank you, everyone.
Bye.